So today what we are going to do actually is focus on information bias. So what is information bias? It is actually any error in the assessment of either the exposure or the outcome. And because of this error is creeping in the assessment, there are systematic differences in the accuracy of information which is being collected for both the groups. And as I said earlier, there are two main types of information bias. It's either the reporting bias from the participant or the observer bias, which is from the investigator. Now, see, when you are collecting data for any of these epidemiological studies, you are the investigator, then there is a respondent, or you could be collecting data, secondary data for, say, exposure or outcome from registers, records, etc. And how is the investigator collecting data? How is the respondent giving the data? And what kind of data is available for the exposure outcome in the records for different groups of subgroups of the study is what needs to be considered for information bias. So if you have two groups and you are making comparisons, if the investigator inherently approaches the cases and the controls differently, that is, they are asking questions differently, the tone is different, the intensity with which they are asking the questions is different, the time spent to collect data with the two is different, then there are going to be uh, differences in the data collected for different variables. Similarly, the respondent. So what is the mood of the respondent? How truly the respondent is going to respond to your questions. So it could vary in the two comparison groups, which could uh, result in information bias. Now, if you are trying to get the exposure outcome data from different sources for the cases, for the controls, or for the exposed, unexposed, and then there are different kinds of errors, or the accuracy of the records is going to be different in these two kinds of secondary data, then also there are going to be systematic differences in the two groups, which is going to result in the information bias. So you have to look at all these aspects to rule out information bias. So let us look at, again, the main idea here is to look at different kinds of study designs and then take up examples to understand the kind of information bias which can happen. So for a case control study, reporting bias, the question you should ask is there a possibility that the participants with the outcome will report history of exposure differently compared to those without the outcome? Now, this can happen because some information is being suppressed or is being revealed selectively. Now, this can be in terms of past medical history, smoking, sexual experiences. Now, these contribute to something known as social desirability bias, some of the sensitive questions, right? But if people in both the groups are going to be, uh, going to be influenced by social desirability bias equally, then it might really not cause bias. But if this kind of the response from the respondent is different in the two groups and it is associated with the outcome also, then we would be worried about information bias. Now, for example, if you are looking at the study between the healthcare workers using personal protective equipment and their usage of personal protective equipment and COVID-19, now, if you do a case control study, you recruit individuals with and without COVID-19 and you ask them history of personal protective equipment. Now, the way the healthcare worker who has had the infection or who has the infection will respond to the question would be different from that of the control. Now, this could really not be the true picture of the actual use of the personal protective equipment. So there could be a reporting bias here because this is self-reported use of personal protective equipment. You are not resorting to any objective tool to assess the use. So how to prevent this kind of reporting bias? You could use objective tools, sources. There could be some records, reports, or some kind of exposure data which would have been recorded before the disease occurred. These kinds of approaches could help prevent this kind of reporting bias. A very common type of reporting bias is a special type known as recall bias, where there are systematic differences in reporting the exposure in terms of either the accuracy or the completeness, in terms of the memory of past events or experiences. So you are looking at the disease, non-disease status, and you are asking about exposure in the past. Now, this is a classical example which is usually given with recall bias. That is a mother whose child has died from leukemia. You are asking her about her details of her antenatal care, including exposure to X-rays. So a mother who has this experience of losing the child will remember the details of the past experiences to a greater depth as compared to a mother who has not had such an experience. So this is going to, so in one group there is going to be a systematic error, and that is going to lead to a bias. Now, many a times when we are really looking at a potential scenario where a recall bias can occur, apart from looking at, say, objective criteria, one way where the respondent, the respondent can commit an error, there one suggestion is to consider incomplete or partial disclosure when you are taking informed consent. So this kind of partial disclosure is where you do not give all the details to the participant, that is details in terms of your hypothesis and what you are actually studying. This is allowed only if there is no more than minimal risk for the participant for participating in your study. But however, all these kinds of studies where you are planning for partial disclosure should undergo a full committee review in the ethics committee, and there should be debriefing. Debriefing means at the end of the study, you should tell the participants, see, we have collected all the data. We did not tell you the entire hypothesis and the study details, but we are telling you all the details now. This was actually our objective. And now are we permitted to move ahead and use your data? And again, once again, the respondent has to give consent for us to move ahead with the data. So are you all getting me here?
Yes,
Yes, ma'am.
ma'am.
So basically, wherever we feel that if we disclose or give all the details of the study to the study participant, there can be a biased response. There can be a recall bias, respondent bias. This is an option. Now, in many ethics committees, because this is not routinely done, not routinely practiced, many are not aware. The ICMR document on ethics committee does mention about incomplete partial disclosure, and you can read through it, and you can refer to this document and show it to your committee if ever you decide to include this kind of disclosure in your consent form. Then in the reporting bias for intervention or cohort study, our worry is whether the study participants with the exposure will report the outcomes differently as compared to those who are not having the exposure. For example, you are doing a study to assess adverse events following COVID-19 immunization, and the patients are aware whether they are getting the vaccine or the placebo. Naturally, the people who are in the vaccinated group are going to be, more alert to the symptoms and may report even small symptoms to you, which may be neglected by those in the placebo group, and this can result in information bias. So can you do blinding, if at all, which could be a bit difficult, but here you could possibly do binding for such kind of a study, or other objective tests, like instead of just self-reported outcomes, is there an objective way of assessing the outcome to verify whether the outcome has really occurred or not in the exposed and the unexposed group. So you should try and replace the subjective self-reports with objective tests, and wherever possible, blinding not just in the intervention studies but also in your cohort studies, you have to consider as a possibility. Now coming to the observer bias, that is, what is the role of the investigator? Again, beginning with case control studies. Now, if the investigator is aware of the outcome, whether the respondent has the outcome or not, then the way the investigator records exposure history could be different for those with and without outcome. So if you are trying to, for example, study the delays in treatment seeking, and the patient's health status, that whether the patient has severe complicated COVID-19 at hospital admission, and the investigator knows whether the patient has severe complicated form of presentation or not, then the investigator may be biased in deciding whether there has been a delay in treatment or not. So again, is there a way of doing blinding? That is, I know, I think it would be difficult in this scenario, but one person decides upon the outcome and then another person takes a history from might be some informant about whether there is delay in seeking treatment or not. For other outcomes, again, try and replace subjective reporting with objective tests. And for any kind of bias which can creep in because of the investigator, we should look at training the health personnel or the investigators so that they follow standard operating procedures for data collections, which will ensure that bias does not occur. Now, in intervention studies, how can the role of the investigator be important? Again, the investigator, if he or she knows the exposure status of the participant, there can be errors in the recording of the outcome. So again, if the investigator is assessing the adverse events following COVID-19 immunization and they know the exposure status of the participant, then the way they will decide upon the presenting symptom as AEFI will be or could be biased. So to prevent this, again, can you do blinding of the investigator? Can you use objective tests? And can you train and provide SOPs to the investigator to make such kind of decisions? So these are ways of preventing information bias. So we have covered majority of these things in our examples, that is blinding, SOPs, then explicit objective criteria, definitions. Then instead of looking at self-reports, can we have some records or biospecimens which are banked in the past, which objectively help us assess about the exposure status using validated tools and questionnaires, pilot testing, training, and data monitoring audits. And then of course in the consent, I told you in the incomplete, giving incomplete or not the full details of your study is what can be practiced when you're taking consent. So this is about information bias. Now, when information bias occurs, this terminology also comes up, which is known as misclassification, because when there is information bias means you are making errors in noting down exposure outcome data. Individuals are going to be assigned to the wrong exposure or outcome groups. And this is known as misclassification. Misclassification merely means that people who are exposed are categorized as not exposed. People who are not exposed, you say they are exposed. Those without outcome are categorized as having the outcome, and vice versa. Now, this misclassification can be non-differential misclassification or differential misclassification. Now, non-differential misclassification is the probability of misclassification given the true value may be the same in all the study groups. Means the error, the information bias which is there is happening to the same extent in your both the comparison groups equally. That is non-differential misclassification. Differential misclassification means the error which is happening in recording the exposure, the outcome is happening purposefully or in one group only and not in the other group. So when you are reading literature, you should see whether your information bias is focusing only on a particular group, the intervention or the control group, or it is likely to happen in both the groups equally. Usually it is said that if there is non-differential misclassification, meaning both comparison groups, the errors are occurring equally, then your estimates are going to be pulled towards the null. And if there is differential misclassification, that is, the information bias is occurring in two groups, say the case group, control group, or the exposed or the unexposed group, then we cannot predict the magnitude or the direction of the effect of this misclassification on the effect estimate. I just want to highlight here that you will need to read more about misclassification, because this is a very tricky concept. But when you talk of information bias, the implication is that the information bias is going to lead to misclassification of the exposure status or the outcome status. And then this is going to have an impact on the effect estimates. Are you with me here?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah, thank you. So again, I'm not going to go through this. These are just the questions, the set of questions which you need to ask about information bias. So why I'm showing these questions is because I feel that if you learn get the habit of asking questions, whatever is being reported, you ask questions at each and every step, whether this could result in bias. If you ask the correct questions, then you can identify the possibilities of the bias coming in, and then also find out ways and mechanisms of preventing that bias. So set of questions for case control study or for cohort and intervention studies. And then of course, you should also learn to ask the question about, can the respondent, tell me, give answer to this particular question. Means can the respondent tell me this, and will people tell me this? Do you think these two are two different questions, or are they the same?
Ma'am, the two different questions.
How are they different?
Ma'am, it is first question is about the ability, ma'am, and whether like they know about it, will they be able to tell about it, and is about consent or willingness to tell that second question.
Yes. So can people tell me this? Means, do the people actually have the knowledge, the ability to tell me this? So if you ask, say, the amount of salt you are consuming in a day, so people may not be in a position to tell the exact amount of salt they are consuming. And will people tell me this? Means, are they comfortable sharing that information with you? So these kinds of questions also you should ask when you are, building up your tool for data collection, your questionnaire or your interview schedule. Whether because this is going to help you understand how truly you are going to be able to capture the data which you need to answer your research question. So